There's only two things that parents want. When a disaster happens to parents and they lose their child, there's two things. One, they want to understand what happened. And the second thing is that they never want that to happen to another child or another family. And so here, this is me trying to make sure it doesn't happen to anyone in Austria. We're all one big family as critical care clinicians around the world. And, I just want to be there with you guys, to give us the opportunity to do the best thing that we possibly can. Because you never know, it might be someone you love one day.
Liebe Zuhörerinnen und Zuhörer, willkommen zurück zu einer neuen Episode des Response Notfallmedizin Podcasts der Berufsrettung Wien. Heute mit einer Premiere, die mich und mein Team offen gesagt einiges an Überwindung gekostet hat, denn wir haben uns entschlossen, sie in englischer Originalsprache rauszubringen. Warum tun wir das? Gleich vorweg, unser Podcast richtet sich vorwiegend an ein deutschsprachiges Publikum und das wird auch weiterhin so bleiben. Dennoch kommen ich und mein Team hauptsächlich über unsere persönlichen Netzwerke in die Notfallmedizin immer wieder auch mit Menschen aus dem englischsprachigen Raum in Kontakt. Menschen, die mit ihrer Botschaft einen enormen Mehrwert für unsere Community mitbringen. So wie zum Beispiel Ben McKenzie, Emergency Physician aus Victoria in Australien, mit dem ich mich heute einmal mehr über das Thema Anaphylaxie unterhalten werde. Ben hat im Jahr 2021 auf unvorstellbar tragische Art und Weise seinen 15-jährigen Sohn Max an die Folgen einer anaphylaktischen Reaktion verloren und widmet seither einen Großteil seiner Karriere dem Kampf gegen die Anaphylaxie. Ein Kampf, in dem es auch um mehr Awareness innerhalb der notfallmedizinischen Community geht. Denn wie der Fall von Max McKenzie eindrucksvoll zeigt, gibt es, wenn es um die rasche, zielgerichtete Behandlung crashender Anaphylaxie-PatientInnen geht, immer noch viel Luft nach oben. Insbesondere bei denen, die sich trotz Adrenalingabe weiter verschlechtern. Nach der Aufzeichnung dieser Folge haben wir lange darüber nachgedacht, wie wir die Inhalte trotz englischer Sprache wohl bestmöglich an euch weitertragen können. Anfangs gab es die Überlegung, die Folge vielleicht KI-unterstützt zu übersetzen, doch das haben wir schnell wieder verworfen. Zu viel an Detail und auch an Emotionen geht dabei einfach verloren. Deswegen haben wir uns dazu entschieden, die Originalversion online zu stellen. Mit der großen Bitte um euer Feedback. Betrachtet diese Episode als Blueprint für weitere englischsprachige Inhalte und lasst uns wissen, ob das so für euch in Ordnung geht. Teilt uns mit, wie euch die Folge gefallen hat und ob wir auch weiterhin von Zeit zu Zeit englischsprachige Inhalte publizieren sollen. Auf euer Feedback freuen wir uns entweder direkt per Mail an response.podcast@ma70.wien.gv.at oder auch gerne via Social Media, zum Beispiel als Direct Message direkt an mich. Mein Username ist @drbental. Für alle nochmal zum Mitschreiben unsere Mailadresse response.podcast@ma70.wien.gv.at oder direkt an mich @drbental. An dieser Stelle danke für euer Feedback, eure Experimentierbereitschaft und letztendlich auch für die Treue zu unserer Sendung. Wir nehmen diesen Herbst kräftig an Fahrt auf und werden euch auch weiterhin spannende Inhalte aus der Welt der Notfallmedizin liefern. Doch jetzt wünschen wir euch erstmal gute Unterhaltung bei unserer ersten, im wahrsten Sinne globalen Episode 22.
Du hörst den Response Notfallmedizin Podcast. Deine Wissensquelle zur spannenden Welt der Notfallmedizin. Präsentiert von der Berufsrettung Wien.
Bitte beruhigen Sie sich und geben Sie mir eine Rückrufnummer, ja?
Durch die heutige Sendung führt dich aus dem Team unserer Oberärzte Dr. Ben Thal.
Ben, it is such a pleasure that we managed to connect today across a distance of, I just looked that up, 15,754 kilometers to discuss the topic of anaphylaxis and asthma. Good morning from Vienna and a warm welcome to our first English language podcast episode. Thank you so much for being with us.
Hi, Ben. Thank you so much for having me and thank you for letting me speak in English. My high school German is nicht so good. Hello from Australia.
But you did German in your high school time, is that correct?
I did. And I had a Swiss girlfriend for a little while, but Schweizerdeutsch is different from High German, and it didn't help me.
I know. I was born and raised in Switzerland, so I really know what you're talking about. And even I myself chose Austria as a place of living, so I really can understand that. Now, today we will be talking about a very important topic. Throughout our whole preparation of this episode, I had the chance to talk with you a little bit. I had the chance to consume all the content and this on your website. It's all about anaphylaxis and asthma today. And this is a very important topic. I myself had 3 severe anaphylaxis cases this year. And still there are a lot of paradigms and ways of thinking out there that can be optimized, as we're going to discuss in our episode today. Now, anaphylactic reactions are a regular part of our operations. And in Vienna, we are dispatched regularly, especially in the warmer part of the year, for allergy-associated emergency codes. However, the patient group you're addressing with your initiative, AMAX-4, represents only a small portion of this patient population. Could you provide us with an overview of the facts and figures and tell us a bit more about the epidemiology behind anaphylaxis?
Yeah, sure. So anaphylaxis is something that is increasing in incidence worldwide. It is something that clinicians will become increasingly exposed to. So it's something that you're going to be faced with more frequently as the years go past, and we have no idea why that is the case. In Australia, it's 5% a year. The UK, it's 5% a year. I don't know what the figures are for Germany, but it's common and becoming more common. Now, the first thing to say is that anaphylaxis deaths are rare. And it's an interesting disease because the inflammatory mediators that are released in response to an allergen have very short half-lives.
Yeah.
And it's a self-limiting disease, I should say. So you can have a mild version that gets better by itself, and that's hard to measure. But if we look at deaths and fatalities, it's 0.1 to 0.5 per million people.
Yeah.
Now, that death rate is low, but that's because so much effort is placed into avoiding exposure to allergens. We have food labeling, we have insect desensitization programs with allergists, we have drug medication labeling, safety mechanisms. So there's this huge investment that creates this low fatality rate. And it's really important that we as critical care providers make sure that death rate stays low, because everybody else is trying to help avoid allergy deaths. And we have a very important part to play, which is the last stopgap. So it's a rare event. Asthma arrests are much more common. It's just worth mentioning the intensive care data for anaphylaxis. So from US cohorts, and there's a 5,000 adult patient cohort study that's just been published from Australia, where the work that EMS, paramedics, doctors, emergency medicine does is crucial, because the ICU length of stay for anaphylaxis is less than 24 hours. And 50% of the people who go to ICU are better before they get there, and they need no organ support. It's a short disease. And so if we can keep somebody alive for 4 hours uninjured with their brain intact, they will walk out of hospital the next day, excluding complications. So it's a short disease. So half of the people who are on organ support in ICU are ventilated, and half need cardiovascular support. But the outcome is completely dependent on what happens before ICU. Now, if you want me to give the epidemiology, and I think this leads on to one of the other questions we were talking about, is that anaphylaxis most of the time gets better with intramuscular adrenaline. Yeah. And 90% need 1 or 2 doses. So we're talking about outside theatre now. We're not talking about anesthesia. We're talking outside theatre. 90% need 1 or 2 doses in the systematic review. About 7% need 3 doses of intramuscular adrenaline. So we've got 97% that need simply intramuscular adrenaline. Now that leaves a small portion that we're talking about today, but it's important, right? Because this could be your family, your child, your neighbors, someone who you work with.
Absolutely. Now, the thing that came to my mind is when I was preparing this session or this episode was that the grades into which an allergic reaction can be classified vary greatly depending on the literature. So there is lots of different concepts and charts of symptoms that you will have to try to kind of match with your patient. Now, in particular, there are often unclear boundaries as to when allergic reaction is considered anaphylaxis. And additionally, you always emphasize in your lectures that especially in young patients, severe anaphylaxis can sometimes have a delayed onset, developing over a longer period of time, over hours. Now, when we are being called out to an anaphylactic emergency, what are the red flags for you indicating that we should be aware that our patient might be heading towards a catastrophe, as you named it in your lecture?
Yeah, sure. So in terms of that spectrum that you mentioned, it is absolutely a spectrum from just skin symptoms. If you're allergic to peanuts, you might just get an itchy mouth, an itchy skin, or you may have a complete airway or bronchospasm or cardiovascular emergency. And we call it anaphylaxis when there's airway, breathing or circulation involvement. And that's the easiest way to think about it. But if you have a more mild reaction and it's a classical allergen, like it's a bee sting or it's a peanut exposure, then even more mild symptoms need to be recognised as potential acute allergy, because the one thing we know about anaphylaxis is that we can never predict, well, not up until this day, we cannot predict which people are at risk of a severe lethal reaction in the future. So the majority of people who die from anaphylaxis have only had mild versions previously. So yes, most get better with intramuscular adrenaline, but we can't be sure. And on my website, I present the case of someone who got better with IM adrenaline, but the adrenaline wears off and then he has catastrophic bronchospasm and dies in an emergency department. Now, in answer to your question, the most useful thing about when do I need to worry that I'm going to have a disaster or catastrophe on my hands is if there are still significant compromise after 2 doses of IM adrenaline. If you need more than 2 doses of IM adrenaline, then your mortality rate suddenly jumps.
Now, in Austria, the EMS system is physician-based, also in large parts of Switzerland and Germany. And in anaphylactic cases, it always comes to a specific decision point whether they will have to call for an emergency physician or not to be dispatched to the scene. For example, in our standard operating procedures, every time a paramedic is giving adrenaline intramuscularly, the physician is going to be dispatched automatically. And I think what we can take from that statement is that even if we give the patient IM adrenaline and he's in the first phase getting better, there is still the risk that is deteriorating in the aftermath. Is that what you're saying?
So in 90% of cases, that will be enough, but we can't predict which cases it won't be enough. And it's important to understand the pharmacokinetics of intramuscular adrenaline. And that is that there is a peak at 5 to 8 minutes. There's then a decrease in plasma levels for presumably because there's some delayed absorption in the muscle bed. And then there's a peak that lasts 40 minutes, 60 minutes. And so you need to know that you have that adrenaline on board. And as that adrenaline wears off, depending on how many mediators are being released or being metabolized, most of them will be already getting better because they have short half-lives, but some will still be getting mediator release and the adrenaline wears off. And then we don't have enough data to say that a patient's safe just because they've got better after a dose of IM adrenaline. Now, having said that, if you're better after 1 dose, then your mortality is very low. But if you needed 2 doses and you still have symptoms, then your mortality is not zero, that's for sure.
When you mention symptoms, you mean respiratory symptoms?
Yeah. So this is the fascinating thing that I've been looking at with my PhD. My starting point of my PhD is what organ failure occurs in anaphylaxis to cause people to die.
Yeah.
And interestingly, bronchospasm is the predominant cause of death. Partly because I think it's hard to treat. It's unclear why bronchospasm predominates in deaths. It's different from people who survive, right? So the people who we see and we can treat low blood pressure, they get some adrenaline, they get better. So there's that group. But the people who actually die and get really sick and go to ICU, they frequently have bronchospasm plus or minus airway symptoms. Now for food allergies, it's 100% bronchospasm death. They all die from respiratory death. I've read every single case report ever published for the last 100 years. And I've reviewed every coronial death in Australia for the last 20. And it's food anaphylaxis is a respiratory death, mainly bronchospasm with some plus or minus airway symptoms, plus or minus low blood pressure, but it's the bronchospasm that gets them. For drugs, it depends how fragile your cardiovascular state is. 60% bronchospasm, but blood pressure is a bigger problem. And for insects, which you guys have in Austria, it's blood pressure and upper airway, not so much bronchospasm, presumably because there's not many asthmatics.
That reminds me of the case we've been talking about that I presented to you in a quick note from the helicopter as I took off from this catastrophic mission that I had. Now, we've been dispatched to a golfer that was 60 years old. He was just playing a nice par 4, and he got stung by I think it was a wasp or a bee. And the thing was, he even had his intramuscular device, his EpiPen with him, and he deployed it immediately. And then we had a fantastic paramedic team. They arrived at scene like around 10 minutes later. And they also gave the second dose of adrenaline. And even though when we landed with our helicopter on the golf course, the patient was already in cardiac arrest. And I remember that once I intubated the patient, there was not really a problem in taking over his breathing because there was not that big amount of resistance when we ventilated in. But the stuff that we suctioned out of his tube was like pink jelly. Kind of pink jelly, so he must have had kind of a damage to his cells on a cellular basis. That's at least my model that I have.
It's interesting that for some reason pulmonary edema is common. I mean, I presume there was some CPR, standstill pulmonary edema. We don't really understand what happens to the pulmonary vasculature in anaphylaxis. So we have really limited information about that. And similarly, you can talk about Kuhner syndrome and myocardial depression, but his problem was almost certainly just he had catastrophic hypotension because different allergens have different problems. So for insect stings, it's low blood pressure 50% of the time, and the other 50% of the time it's upper airway occlusion for deaths. And it tends to be a smaller group than the food allergy group. But once you've got no blood pressure, IM adrenaline's of questionable value. It just, the absorption's pretty limited in terms of blood supply to that vascular bed.
Absolutely. Now, there are still lots of improvements that we can make in our paradigms when it comes to anaphylaxis treatment. But we also have to emphasize that we are very happy that at least the IM adrenaline reached the heads of the paramedics and the doctors out there. And we are very pleased that IM adrenaline is now being widely used. However, I still have the impression that there are uncertainties about when adrenaline should be administered. Before we focus on the patient group that is already in a very poor condition at our first contact, like, for example, the one I just described, let's address a more general question. What is your personal decision point at which you recommend the use of IM adrenaline? What symptoms does the patient have to show?
It's a great question. I can answer this from an allergist perspective, an immunologist perspective, or I can answer it from an emergency medicine perspective.
Okay.
And I'll give you both answers if you want. The emergency medicine perspective is when there's airway, breathing, or circulation problems. Now, the thing to really impress upon everyone listening is that intramuscular adrenaline is actually super safe. And All of the case reports of adrenaline causing problems are related to excessive, erroneous intravenous boluses that are at the wrong dose. And adrenaline is just safe. It's safe in kids. Even if you get the dose slightly wrong, it's safe. So if you're not sure, there's really not much to lose if you're going to be taking them to a hospital. So one of the common questions I get is, you have a red patient who's super itchy, who's got some tummy pain, but their blood pressure's normal, they're not got bronchospasm, their airway's okay, but they're really distressed and they've got more than one system going on. What do you do? Do you give them adrenaline? And I say it doesn't matter. They're not, their airway, breathing, circulation is okay. If you want to give it, go for it. It'll make them feel better. Yeah. If you don't want to give it because you don't want to monitor them for the adrenaline half-life, then that's okay too. Give them some antihistamine and reassure them. But airway, breathing, circulation symptoms, go for it. Now, if you want the allergy immunology perspective, they say everyone with food allergy gets abdominal pains. Stop giving adrenaline for abdominal pain, because then we have to watch them and observe them. That's one take. And the other take is, the allergists and immunologists, when you talk to them, because they're always doing food challenges or immunotherapy in venom challenges, they're dealing with mild anaphylaxis all the time in their clinics. And so they often get people with a bit of a throat tickle, and they're used to seeing that all the time, and they say, don't worry. But they have risk stratified patients where they've said, you're at low risk, your asthma's under control, you're healthy today, we're going to give you a supervised challenge, and sure, we can tolerate some minor symptoms. That's not our world. We're on the side of the road, we're in somebody's house, we're in the emergency department. We don't know how bad this reaction is going to be. So any airway, breathing or circulation symptoms.
Now, Ben, let me just throw in a quick ad hoc question. How about the patients that do have skin symptoms near their airway, or especially their mouth? Would you already give adrenaline if the patient's only symptoms concerning the airway is a lip swelling, for example? Does the swelling of the lips and the mouth, or an itchy feeling in the mouth, always translate into the lower airway?
Yeah, the answer is no. If you have skin symptoms, they are not dangerous. If you have lip symptoms, they are not dangerous. It does not reflect what's happening in the airway. Now, when we talk about airway, we can talk about the oropharynx and we can talk about the larynx. So, for example, insect swelling, and there's lots of tongue and oropharyngeal swelling. That's usually obvious because you can see the oropharynx and you can see the tongue. So you can actually look inside and you can judge the airway yourself. Now, the larynx is you can't visualize, but you can hear people talking and whether or not they have stridor. So a little bit of an itchy throat, if it's causing severe distress, yes, that's an oropharyngeal, possibly laryngeal symptom. So I would give adrenaline. But if it's just external and it's lip swelling or skin or neck or somewhere on the outside, benign.
Okay, awesome. Now, and there's a second question that relates to what you just said, is you said in your system, it's always obliged to monitor a patient that has been receiving adrenaline. Why is that really not necessary when it's so safe to give, to observe him? Is it because of the possible deterioration of the patient, or is it because of side effects of adrenaline?
Yeah, so it's a really good question. At the moment, we've just set up a registry to try and answer this question in Melbourne, and the Canadians are halfway through their Can Prepare study to try and answer this question with the decision rule. But the reason why we have to observe people is for, ongoing anaphylaxis when the adrenaline wears off.
Yeah.
It's got a half-life. It's the same principle as children with croup who get adrenaline nebulizers or laryngotracheobronchiolitis. I'm not sure what you call it in Germany. It may be that after 1 hour, the adrenaline's worn off, people are safe to go home, but we just don't have that data. And the current guidelines are not evidence-based because there is no evidence. And so 4 hours is just a number. And there's lots of variation in practice, particularly in pediatric settings where it's so common. So we don't know. If you have somebody who's needed 2 doses of adrenaline, they're staying for 4 hours. But there are certainly discussions internationally, and particularly in the States, where healthcare is expensive. Do people need to go to the emergency department after 1 dose of adrenaline? But the short answer is we do not have enough data to make that decision safely yet. Okay. But we're trying.
We're now going to head to the more severe cases that we wanted to talk about. And I want to point out a specific part of your main lecture that we can find on AMAX-4. We're going to talk about this a little later, about all the resources and all the information that you provide on your website. There is one piece of content which is called your main lecture. And you do a very interesting thought experiment in these lectures. Nearly 2 years ago, we introduced the pre-hospital clamshell thoracotomy into the Viennese system, a measure that prompted a rethinking in the management of traumatic cardiac arrests. To just summarize that briefly, in the case of a central thoracic stab wound, for example, it makes no sense to perform chest compressions on a patient as long as the underlying cause of the cardiac arrest hasn't been addressed. So keywords are pneumothorax, cardiac tamponade, aggressive fluid resuscitation in an exsanguinated patient. Therefore, I was particularly surprised when you emphasized at the beginning of the keynote on your website that a similar parallel should actually be drawn in the treatment of anaphylaxis-related cardiac arrest. What are your thoughts on this?
Yeah, so what are my thoughts? My thoughts are that when we're resuscitating somebody, we must target the specific organ failure that's occurred, because through the act of resuscitation, we are providing definitive organ support, because that's our job as critical care clinicians. Now, what is the organ failure that occurs with anaphylaxis? Well, with food anaphylaxis, it's breathing 100% of the time, almost always bronchospasm. So if you have catastrophic bronchospasm, bag mask ventilation will inevitably fail, because the peak inspiratory pressures are too high to be able to generate the air that you move will go down the esophagus. And similarly with laryngeal masks. And even if you have an eye gel, you cannot generate the 50 to 120 centimeters of water into the lungs through an eye gel. It's not possible. So the only thing that's going to save this person's life and oxygenate them is an endotracheal tube. And so if somebody arrests with food anaphylaxis, because it happens regularly, repeatedly, all over the world, that person, that young person, because they're almost always young, needs a definitive endotracheal tube, and because they're hypoxic, and that's why they've arrested. Now, you may be able to temporize things for a short few minutes with a mask ventilation, maybe not. But we know that the hypoxic response of our bodies is to become bradycardic. Once you get down to a PO2 of 21 or 23 or SATs of 40, we become bradycardic. And we've got 4 minutes until the brain starts to die. It's a really, really short time. Yeah. Now, if we do CPR with deoxygenated blood, it's just circulating deoxygenated blood, and it's not going to help the patient in the time that we need to. So you can do CPR, you can do your ALS algorithm as long as it's accompanied by a time-critical definitive intubation and that's the organ support that we need to provide these patients. Because now everybody in the world sends me these anaphylaxis disasters, from all sorts of different countries. People will reach out to me, and it just happens again and again and again. And most frequently, it happens with pre-hospital services. The pre-hospital services are the ones that have the opportunity to give someone an endotracheal tube in a meaningful time frame. So obviously that needs to be accompanied with adrenaline because, there's we want to support their blood pressure. We want to treat the bronchospasm. Adrenaline is this magical drug which helps all the end organs affected in anaphylaxis. And if we don't intubate someone, particularly with food anaphylaxis or drug anaphylaxis, then we're not helping them. And I'm talking about the unconscious hypoxic patient. Or you may not know if they're hypoxic or not, but they're unconscious and you've diagnosis is anaphylaxis or severe bronchospasm. So in trauma, we've got this specific set of instructions to address the pathophysiology that is occurring in that entity. And it's the same in anaphylaxis. We have a multi-organ problem with specific pathophysiology, with specific types of organ failure. So we need to provide definitive care to support those organs in a time frame before hypoxic brain injury occurs. And because remember, these people are going to be better in a few hours. And so the quicker you do things and the quicker you provide definitive care, the more likely they are to walk out of hospital the next day. So it's a bit of a mental leap, as you say. It's a paradigm shift because most anaphylaxis guidelines are silent. They stop at IM adrenaline or an IV adrenaline infusion. So there's nobody talks about what to do and what type of organ failure we're trying to manage.
Let's just try to make this whole thing a little bit more plastic. Let's just jump into a case. Let's think of a 40-year-old patient. Ambulance has been arriving at scene. They recognize the patient who has been, for example, eating some peanut jelly sandwich before, as he's an American tourist coming to Austria. And he's developing an allergic reaction and he's going into anaphylaxis. So he already has, for example, some difficulties in breathing when the paramedics arrive at the scene. And as our standard operating procedure propose, they're going to give them fluids. They're going to give him IM adrenaline. They might want to give repetitive dose of IM adrenaline once the patient is not feeling better, or also if the patient is really severely ill. And then the emergency physician is going to be dispatched, and this patient does not improve from these measures. Now, this is the group that we are going to talk about right now. And to adequately and swiftly address these patients, you and your team developed the AMAX-4 algorithm. And this is just to avoid any misunderstanding. This is an approach that comes after the second dose of IM adrenaline, or at least is addressing patients that are in severe anaphylaxis, so with heavy symptoms. And this approach is always applied when the patient is already unconscious and requires assisted ventilation, meaning we have already moved beyond IM adrenaline. And this is also the cutoff where you take your algorithm out of your pocket. Is that true? So the decision point to go for a tube is at latest when the patient is unconscious and needs assisted ventilation. Did I get that right?
I'm going to paint a picture for you. That 40-year-old is agitated. He's telling you he can't breathe. He may become incontinent. He's sweaty and diaphoretic, but he knows he's dying. And he will become hypoxic on room air. And if you have hypoxia on room air, so we're talking about a food allergy case now. If he has hypoxia on room air, you're about to be in trouble, and you should be setting up for intubation, or at least getting some help so that can occur. You'll be giving your repetitive doses of IM adrenaline. You'll be drawing up your IV adrenaline infusion, but things are going badly. And the thing about both anaphylaxis and asthma is that hypoxia is a late sign, and that agitation and feeling of impending doom and the patient saying, I'm going to die, are late signs. And the decompensation is rapid. So you hopefully you're preparing already to provide definitive care for this patient, and you're going to support their breathing and intubate them. But if you don't make it and they become unconscious right there in front of you and they become bradycardic, you've got 4 minutes to fix it. Now, and that means a time-critical intubation, a time-critical definitive intubation. So when we created the AMAX-4 algorithm, we didn't want to have unintended consequences. So we need to say, look, you've got 4 minutes in this severe group of patients, but hopefully you're already The AMAX-4 is telling you that this is going to be a problem and we don't want to get there and we want to actually act beforehand. But once the patient's unconscious, all of a sudden the patient's dying and hypoxic brain injury is this silent, devastating thing that happens silent in front of you. There's no gunshot wound to the head. There's no depressed skull fracture. There's no blood. The brain is just dying silently. So we need a time-critical tube, and we also need adrenaline that is going to act straight away. So intramuscular adrenaline, the peak is at 5 minutes. That's too far away for us. So we need an adrenaline IV bolus, but we need to do that safely. And so that safe dose is 1 microgram per kilogram as an IV bolus to treat the bronchospasm or the blood pressure or both.
This is one of the takeaway messages that I drag out is these patients need IV adrenaline and they need it in a higher dose than the normal. In Austria, we call it suprablitz, which is the push-dose pressor. Push-dose pressor dosing, for example, throughout an intubation, a normal RSI or pre-hospital intubation is being used in much smaller doses than you will use it in this particular case.
That sounds like a great system that you've got there for push-dose pressors. And yes, it is higher because these patients are almost dead. They're dying. And when they become bradycardic and meet cardiac arrest criteria, we're about to give them 1,000 milligrams if they're an adult, or 10 micrograms per kilogram if they're a child, 10 times the dose because their heart stopped. So what we're doing is giving a dose that's in between the push dose pressor and the cardiac arrest dose to try and avoid cardiac arrest and manage the bronchospasm and the blood pressure and the airway. So in terms of what AMAX-4 is, you can look at AMAX-4 and look at what the individual letters stand for, or you can use it as give adrenaline IV and intubate the patient in 4 minutes, as in a max-4, a maximum 4 minutes. And that's the way I try and teach it. You understand the principles of anaphylaxis. You're going to think about pneumothorax. You're going to think about giving extra doses of bronchodilators. You can use magnesium, that's safe. You can use second-line vasopressors. You can use vasopressin, whatever you want to use. But getting the airway and giving adrenaline in a high enough dose intravenously are the critical things that need to happen within 4 minutes before this patient sustains a hypoxic brain injury. Because unlike every other pathophysiology, even trauma, this happens quick.
Now, you've been mentioning AMAX-4, which is that algorithm that you and your team developed for these cases, and each letter of this acronym stands for a specific task that needs to be done. Like, for example, A stands for IV adrenaline, M stands for muscular relaxant. Can we just go quickly through every single step with a quick abstract behind every letter that is forming this AMAX-4 algorithm?
Yeah, sure. So the A is for adrenaline because we need adrenaline to manage airway, bronchospasm and circulation, and particularly bronchospasm. And we need that in a dose that is not the cardiac arrest dose, that's 10 micrograms per kilogram, but we want 1 microgram per kilogram because these are very sick patients and they're in the process of dying, and we need to give them appropriate bronchodilation and cardiovascular support. So that's 1 microgram per kilogram intravenously, because IM adrenaline takes too long. It takes 5 to 8 minutes to get to a peak. That is a really important step of the A. The M is to really give you permission to intubate and to make you commit to intubation, because we're going to provide definitive airway and bronchospasm care. We're going to do some difficult obstructive ventilation. And so the M is for muscle relaxant. The A is for airway, because we know that either the airway is going to be edematous or that there's going to be bronchospasm, particularly in food and drug allergy, and we can't ventilate without endotracheal tubes. So that's what the A is for. The X is for extra things. So we're going to do extreme obstructive ventilation, so 100% oxygen, low tidal volumes, high peak pressures. Use a bag because it's going to be really difficult to generate the peak pressures that are required to ventilate the lung. Remember, those pressures don't go to the alveoli. It doesn't mean that you're going to have high plateau pressures, but we're going to use small tidal volume with high pressure and with a long expiratory time, so we don't create a pneumothorax. X is for pneumothorax as well. X is for extra bronchodilators like magnesium. X is also for extra vasopressors. So X is for a whole bunch of things, for all the extra things, because unlike most conditions, when we put the tube in, endotracheal tube in most conditions, we mostly relax and go, oh, thank goodness, the drama's over, the tube's in. But with anaphylaxis and asthma, it doesn't stop there. Like, it's still a challenge because you've got to do this difficult ventilation and give high-dose bronchodilators.
So these letters also put things into the right order. So this is also proposing that IV adrenaline, muscular relaxant, and bringing that tube in are the measures that need to be addressed in the first place, and then come all the extra efforts that you were just talking about.
Yes, that's exactly right. Thanks for clarifying that, Ben. And the 4, of course, is 4 minutes, because people don't appreciate how rapidly hypoxic brain injury occurs, and it's such a devastating thing that affects the hippocampus and the basal ganglia and the occipital cortex and the cerebellum. It's very characteristic. It's always the same, almost always the same, and it's devastating, and it happens really, really quickly. So it's to address the human factors and to say, actually, you've got 4 minutes to do this. We're going to have one look for intubation, and then we're going to do this quickly, because we can't ventilate them any other way. We can't oxygenate them any other way.
I have to admit, this is the hardest question that I ever was about to ask one of my podcast guests. But the reason why you have dedicated so much effort in recent years to raising awareness about the treatment of anaphylaxis patients has deeply affected not only me, but also everyone I've shared your story with. And most of us have families with children at home. And it's beyond all of our imaginations what you must have gone through as a father and then as a doctor when you couldn't save your own 15-year-old son a few years ago during the most severe manifestation of anaphylaxis, literally right under your hands. And yet you found the strength to continually address this case in your lectures, as it tragically illustrates everything we've discussed over the past hour. First of all, thank you so much for sharing this case with us and giving us the opportunity to further improve our own treatment strategies and learn from this case. And I think at this point, I would feel most comfortable to just let you speak freely without asking specific questions. Could you tell us what happened to your son, Max?
Yeah, thanks, Ben. I miss Max a lot, and most days it still feels surreal that he's not here, because I expect him to walk out of his bedroom. Max was staying with his grandma, and he ate an apple crumble dish which had ground walnuts in it that his grandma had got from somewhere, and she gave it to him. Max stayed with her many times. Max became wheezy and itchy, and he did everything right. He used his EpiPen. My wife, his mum Tamara, was already there to pick him up. It was just around the corner to pick him up and take him home. And she called the paramedics and the EMS service. And when the paramedics got there, Max, they said, "Max, you look wheezy. You sure you don't have asthma?" And he said, No, this has happened too quickly. It can't be asthma, and it has to be anaphylaxis. But he didn't realize what had happened because he thought that he wasn't eating any unsafe food. But he goes, there must be something in that dish, in that food. And so the paramedics said, okay, fine. So it took them 10 minutes to give adrenaline, IM. And then the total scene time, really, it was half an hour. And the hospital was 6 minutes down the road, driving. And during that half an hour, Max became progressively worse. So he was fine at the beginning. So he didn't look sick. He was able to talk. He had just hopped out of the shower, but soon he was sitting forwards and having more difficulty breathing. And they administered some oxygen, they administered some salbutamol and some ipratropium, so, some bronchodilators via nebulizer. They then gave the second dose of adrenaline 10 minutes later. It should be every 5 minutes. That's the idea. I'm not sure what your protocol is, but he became progressively hypoxic. And as they took him out to the ambulance, he was becoming increasingly sweaty and his work of breathing was becoming harder and he was becoming more hypoxic. And when they put him in the back of the ambulance, he became incontinent. And there was some confusion because there was a junior paramedic and there was some delays, and eventually they started driving. And a few minutes from the hospital, he said, "I'm going to fucking die." And he then had this agitation where he started reaching around the ambulance, trying to hold on to something, and eventually he became unconscious and became bradycardic. And so what the paramedics, the EMS, did was give him an IV dose of adrenaline, which was effectively the cardiac arrest dose. It was an intramuscular dose of 500 micrograms, but they gave it IV, which was the right thing to do. And they did some mask ventilation. And a few minutes later, they were inside the emergency department on the stretcher. So now Max is unconscious. He's having some mask ventilation. And he's on an emergency department trolley with a specialist emergency medicine doctor, 2 specialist emergency medicine doctors, a trainee doctor, a bunch of nurses, the paramedics, everyone's there. And nobody does anything really for 10 minutes apart from give him an IM dose of adrenaline because they think that they can ventilate him. In this situation where you have catastrophic bronchospasm, his bronchospasm just got worse and worse and worse and worse. You're only ventilating the esophagus. If you think you can ventilate someone, if you think you can mask ventilate someone, most of that will probably be going down the esophagus if there's been an unconsciousness from hypoxic asthmatic arrest. So then mask ventilation fails, as it inevitably does in these cases. He becomes bradycardic. They start CPR. I arrive 17 minutes after Max got there and he's still not intubated. They're doing CPR. I see that Max is asystolic. And I watch them perform their third intubation attempt. And as that intubation attempt, for some reason they're having difficulty, and we don't know whether that was because there was multiple attempts or because there was some laryngeal edema. Max had no laryngeal symptoms 4 minutes from the hospital.
Yeah, that's a disaster. And
so as they pull out the tube, I say, he needs a scalpel finger bougie. He needs someone get the scalpel, and someone gets the scalpel from outside the cubicle, brings in the scalpel, and the emergency medicine doctors have handed over his airway to an anaesthetist and an intensive care physician, and are somewhere at the back of the room. And the intensive care physician makes the cut in Max's neck. But because she's on the head side of Max, on the intubating side, she can't get her finger and her bougie in. And so I have to walk around, because nobody's next to Max's neck. I have to walk around and put my finger in Max's cricothyroid membrane myself and put the bougie in and put the tube in. And then, and I just remember that the blood was so cyanotic, it was almost black. Like there was not a molecule of oxygen left in this blood. And as soon as, then the anaesthetist was making these ineffective ventilations, so I took over ventilation. And as soon as we gave Max some breaths, very high pressures, they felt like stiff, obstructed lungs, asthma type lungs. But as soon as Max had oxygen, his heart started again. And, I should say in the ambulance, when he got some oxygen, his heart, he was tachycardic again. So when he arrived in the emergency department, his heart rate was 140, his blood pressure was 130, his sats were in the 80s. So when he arrived, there was this opportunity, and there was certainly this opportunity before the hospital, But the person that ended up having to direct the intubation and complete the procedure was me, his dad. And it's just not a dad's job to resuscitate your own son in a hospital that's not yours. And if people are thinking, how did he get into the hospital? Well, I was in my ambulance uniform, and a paramedic EMS drove me lights and sirens to the hospital, and we let ourselves in. And people didn't know I was the father. You know, that's our job as critical care specialists and critical care staff is to do this, you know, these time critical things that need to happen. And everyone should be able to intubate rapidly. It's one of the core jobs that we do. And so Max was hypoxic for too long, and he had a catastrophic hypoxic brain injury. He ended up dying on day 13 because he had brainstem instability, and he had this, you know, sympathetic overdrive, then would get some clonidine and become bradycardic. And he was quadriplegic. He could not see, but he could hear, and he could poke out his tongue to say, Max, poke out your tongue. He would poke out his tongue. He was so brain damaged, and we were looking at having this disabled child come home. But then Max made his own decision to say, this is not the way I'm going to live. And so he decided to exit this world. And that was a really traumatic thing that happened. And there's only two things that parents want when a disaster happens to parents and they lose their child. There's two things. One, they want to understand what happened, and the second thing is that they never want that to happen to another child or another family. And so here, this is me trying to make sure it doesn't happen to anyone in Austria. We're all one big family as critical care clinicians around the world, and you know, I just want to be there with you guys, you know, to give us the opportunity to do the best thing that we possibly can, because you never know, it might be someone you love one day.
Good Lord, there are absolutely no words, and I just can say thank you for sharing this story. I mean, there is so many things that we can learn from this. And as somebody who is and amongst our whole team here trying to improve also the human factor processes within our company, this just illustrates the holistic room for improvement that we even have in high sophisticated rescue systems. And it simply leaves another loving dad speechless.
Yeah, I just said hopefully everyone can take something away from Max's story, and you know, everybody wants to do the best when they turn up for work. Everyone wants to do the best by their patients, and we just need to give everyone the tools to be able to do their job.
Thank you so much for joining our podcast. I'm trying to do my best to spread the word as good as I can within my little microcosmos. But yeah, I just gonna put all the information in our show notes for those guys who will not find the time to jump to their computer and look it up. Could you once just reference the website? I think it's AMAX-4.org, is that correct?
Yeah, that's right.
Yeah. And you're going to find loads of information there. You did a big lecture on the whole topic. You even separated all the letters of the AMAX-4 procedure into small little bits. So you can just jump onto AMAX-4 and just review it once again and just get the things out that you're interested in. And what we forgot to mention is that nothing, and this is very important, for our listeners out there, nothing within the AMAX-4 algorithm is new and nothing is not evidence-based. Everything within this algorithm is evidence-based information and doesn't violate any kind of standard operating procedure or literature or guidelines at all. So it just puts things in the right order. And this needs to be the key message that we have to bring out there. It's not about inventing the process new. I think it's about implementing human factors, good crew resource management into our processes, not stopping that processes, and especially in anaphylactic patients, it's just about reordering everything that we know in 2024. Would you agree?
That's very well said, Ben. That's exactly right. There's nothing new.
Thank you so much, and let's just stay in touch. We're going to follow your project, and I hope we're going to hear us soon on our podcast again, maybe in future.
Thanks very much, Ben, and thank you again for everyone for listening to me in English. And I hope everyone is well, and my love to all your families. Take care. Bye from Australia.